Hey, everybody. Welcome, welcome, and Happy New Year. I am going to get rid of somebody else will take care of the chat function, I suppose. Welcome, 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 welcome. A lot of people coming in. We're going to give it a couple of minutes, and then that way we can have all kinds of people coming in. If this is your first ever Appalachian Partnership Consortium meeting, can you maybe just use the thumbs up emoji? If you're new to this and true to this, put in a little emoji. I don't know. I don't see anybody with a thumbs up, so looks like you all have been coming here for a while. I like that. I like that idea. I like that idea that you all been here before. You know, I would make some other jokes, but I don't know y'all that well. And for all the CEG staffers, y'all can go off camera and stop being, see you, hi. But now I don't need to see you anymore. Goodbye, see you. Yeah, see? All right. There you go. This is a fun thing. So for those of you who are new to this, right? And I don't think many of you are, we try to have fun with this. We take an hour of your lives that you'll never get back. But hopefully you'll either learn something in the process or meet some new people in the process or get a new thought partner in the process. Yeah, I said thought partner out loud. I said it and I meant it with my chest. So it is now 2:02. So I'm going to start introducing people. Again, if you want to say hi to folks, let folks know who you are, put it in the chat. If you've got a question, you can go ahead and put that in the chat. And somebody from CEG is monitoring the chat, so they'll actually probably text me the question that you have. If my phone, I turn my phone off, so they'll just yell out what the question is. Because if I don't turn my phone off, I'll play with it. All right, first thing I'd like to do is introduce our panel of the day. Some of them are friends, some of them are colleagues, and one guy, I never met this man before in my life, but he sounds like he knows what he's talking about. So you can pick him apart and let's see if he does. First person I'm going to introduce is a dear friend and colleague, Dr. Daniel Driffin. Dr. Driffin, would you like to tell the people who you are and what you do?
Hey everyone, and thank you, Tony, for inviting me to this meeting. My name is Daniel Driffin, he, him pronouns, and I am a public health analyst. I really sit at the intersections of how do we involve community members, how do we involve those with like everyday expertise to really lean into just creating better systems to take care of our friends, to take care of our family members, to take care of the next door neighbors. So I'm happy to be here.
Perfect, thanks. Now, somebody who's not new to this, but true to this, Audrey, you want to tell the people who you are, what you used to do, and that, you might be looking for a job.
Thanks, Tony. I see many familiar names here. I'm Audrey Smith. I used to work for Senator Joe Manchin until just very recently with his retirement. I handled his healthcare policy for the last 6 years, but I have 12 years working in healthcare policy, specifically with West Virginia. So happy to speak to some of the work we did there, specific to working on Appalachia specific priorities.
Perfect. Thanks a lot. Now, my new friend, he doesn't know, well, maybe he does already know that he's not going to be my new friend. And I'm going to be calling him about 11, 15 waivers and some more junk. Why don't you tell the people what you do?
Great. All right. Thank you so much for having me here. My name is Dan Mistak. I'm actually calling in, just so you all know, from northeastern Ohio, Ashtabula County, which is the actual Appalachia part of Ohio, even though it's totally flat where I'm at. So it's really great to be a part of this group here. So I work at a nonprofit called Community Oriented Correctional Health Services. We were started back in 2005 with a grant from the Robert Wood Johnson Foundation to improve connections between community health systems and correctional health systems. So for the last decade or so, I've been working on trying to craft 1115 waivers to allow for Medicaid services inside of the jail, and also to try and figure out who's going to be the provider once we open up these services. So we've had a lot of great success at the last half of last year, and I'm really happy to be here and share this with you all. So thanks so much.
Perfect. Thank you. And so, like I said, if you're new, meaning even for the panel, I interrupt a lot and I ask questions a lot and I follow up on what you said a lot. So Dan, is it Dan or Daniel?
Daniel, if I'm in trouble, but Dan, if everything's going all right.
Hey, Dan. Okay, we'll
All
see.
right. All right.
So Dan, first things first, one of the things is tell people what an 1115 waiver is.
Yeah, sure. So Medicaid is a part of a bill called the Social Security Act. It's been the law of the land for a long time. But really, Medicaid is a state and federal partnership. So that means each state crafts their own Medicaid plan. And also, as a part of that, there's an opportunity for a state to say, you know, we like this part of Medicaid, but we think we can do it better our way. And so what happens is a state's then allowed to use an 1115 waiver. There's also other waiver authorities. The numbers actually apply to the section of the statute that is being used for the authority to apply for a waiver. And so one of the waivers, so then a state applies for one of these waivers and says to CMS, the agency that governs Medicaid, hey, we think we can we can meet the goals of Medicaid a little bit better if we do it this way. Will you allow us to waive that? And we promise it's not going to cost you any extra money. So the waiver that I've been focused on specifically is the component of the Social Security Act that means that the moment you're booked into a jail, you lose access to your Medicaid services. And that causes huge discontinuities of care. It ends up costing a lot more for the Medicaid system to have that happen. And so we have been trying to say that the federal government actually has the authority to waive this inmate of a public institution exclusion. And so we have been working with the federal government and states in order to get some of these waivers through.
Perfect. Thanks, Dan. Yep. No, just kidding. So Audrey, you know, I have been a proponent of us getting rid of the HRSA's rural health analyzer. Some people call it the rural health calculator analyzer. But for those of us who apply for, you know, any federal grant that seems to fall out of the sky through HRSA, rurality, the defining of rurality, you know, we can use the 423 counties of Appalachia as defined by the Appalachia Regional Commission. But throughout the rest of America, this definition of rurality changes agency by agency almost. Not almost, it really does. HRSA uses the analyzer. Some other agencies use the analyzer. Some other agencies say it's about population distance from an urban center. Can you tell me some of the, I already know the answer to this, and I'm doing a bad lead because I actually think what you came up with was genius. I think it's the smartest thing that I've seen. That, you know, I'm putting you now, you and Sally Hodder get my the CEG Genius Award for me. I just think this is the smartest thing I've seen.
Thanks, but I really can't claim all the credit for that. That's honestly a big team.
Knows. Nobody knows.
But I think it's thank you for that question. Yeah, there's different rural definitions across federal government programs. Obviously, in the HRSA space with the grants, some of that is to better direct the resources to areas that they're deeming need it the most, just because there's a limited number of resources. And when you expand that definition, sometimes you can get a little far where you might have suburbs in large urban communities that now have access to that, which would still which would limit resources to areas of, let's say, Appalachia. So this was something that we had discovered while I was working for Senator Manchin, was that there were many communities, specifically in West Virginia, that were ineligible under that analyzer for rural healthcare grants. In particular, critical access hospitals, so your most rural type of hospital in counties such as Boone County, West Virginia. If you're familiar with Boone County, it's very small. It is next to Kanawha County, where Charleston is. But there's no definition, which most people would assume that Boone would be considered urban. So what we worked on and what we discovered was that definitions are predominantly based on either population density, population size, commuting patterns. And when you live in mountainous terrain areas like Appalachia, you actually live fairly densely along regions such as like highways. And the kind of elevation and travel through those regions wasn't being calculated into these rural areas. So we had something developed called the road ruggedness scale. What it measures is actually the ruggedness of the terrain that people are commuting through. This actually coupled with those commuting patterns and population numbers, actually found that Appalachia, West Virginia in particular, are in fact the most rugged states in the United States. For comparison, about 11.7% of the US population lives in what would be deemed a rugged area. That's compared to almost 82% of West Virginia's population. So it shows that kind of disproportionate way that individuals in the state are living. And that impacts things like their ability to access needed services, and in this case, public health services. And so we had been working on getting this adapted into that rural health analyzer. Happy to say that 6 counties in West Virginia have been properly redesignated from urban to rural, and certain census tracts in Raleigh, Fayette, and Kanawha County have also been redesignated. There's still some work to do here, but very excited to have this new tool that helps.
Now, Dr. Griffin, I'm coming to you in 1 second. How can we access this new tool? How do we access this new tool for those folks that might be on here that want to use this to write a grant or to maybe even make the case for their county?
Yeah, so it was actually created by the USDA Economic Research Service, ERS. So you can Google USDA road ruggedness scale and see this. You can also now use the Rural Health Analyzer to type in some of those new addresses. The latest rule that was published was on November 21st. It was called the Inclusion of Terrain Factors in the Definition of Rural Area for the Federal Office of Rural Health Policy. So you could read a little bit more about their thinking about using the road ruggedness scale. There's also a number of, if you could still access some of Senator Manchin's work and timeline and a lot of our letters and work that we've done on this. But specifically, I would go to the USDA for that tool, which is independent on its own. And then HRSA has, in fact, adapted that tool into their analyzer. It does need to be adapted to other rural definitions, but this is a start.
Well, thanks. And I know Lavina's put a link in the chat for those who may want to take a look at it. We'll also, like everybody else, we'll send out the links and all of that after the call as a part of the follow-up. But in the meantime, and don't get distracted playing with it while you're on the call. Wait, back to the call. No playing with the analyzer right now. All right. Dr. Griffin, one of the things I really wanted to talk to you about is like one of my personal missions. I think we've known each other a long time, and everybody's kind of sick of hearing me walk in the rooms talking about Appalachia at this point. But the reality is that can you maybe tell us a bit about where we are with research and engaging rural communities? Because I believe that the folks that are impacted, that Dan was talking about, the terrain that Audrey's talking about, if we can't figure out how to access people at risk for living with HIV, living with hepatitis C, and this outbreak of syphilis, particularly people who inject drugs, have used drugs, have a history of substance use disorder, and engage them in our research, but also just engage them in access as a part of the continuum of care, treatment, and cure. Can you tell me anything that you're seeing on the horizon?
Yeah, I mean, to answer your question from the start, we're not doing nearly enough. When we think about, where those individuals who are the most marginalized, oftentimes they are not living in our city centers, even when we think about how much it is costing to let alone buy groceries, but to just pay rent. People are being pushed further and further from, our city proper locales. So I would definitely say we had to do a much better job of engaging folks outside of the cities in our rural communities. I think it starts by changing our definition of, what are deemed traditional research sites. For a very long time, they've only been those clinical universities, where you could buy a t-shirt from your everyday department store. But we really have to think of research being in our neighborhoods. So having our researchers leave their institutions and really come to the local watering hole. that is a diner at the corner of Main Street in Apple Way. We have to think about how do we create more programs meeting where people are versus demanding where we want people to go.
Well, I mean, since it's 2025, I'll start us off where I always start us off, right? And that there's a train roaring through Appalachia. The engine of that train is the Oxycontin crisis that so many of us knew. And now it's the poly drug use crisis. We've got hepatitis C, hepatitis B, hepatitis A, educational attainment challenges, economic development challenges, workforce development challenges, with the caboose of that train being HIV, a sidecar, syphilis. I used to say that the train was laden with coal. I think that now the train is actually just laden with, I think some of it is fear, some of it is worry, but some of it is just economic confusion, right? And I think we've got to be the boulder that stops that train in its tracks. And we got to do that by bringing resources, opportunity, and attention to this region, but also to rural communities across America. And Dan, I'm actually kind of going to come back to you with this because, kind of no matter kind of what we see on the time horizon into the future, the reality is that as folks are transitioning out of jails, prisons, and other institutions, these are our workers also of the future.
Right.
These are workers going to go back to Main Street. So help me understand. I think I got it with what you're doing with the 1115 waiver, but let's talk about 1115 waivers and beyond. So what are the workforce, and Audrey, I'm going to talk to you a bit about this too. The workforce development, and you're like, I don't know nothing about the workforce, but the workforce development pieces of this that we might need to be thinking about. What are the Department of Labor pieces that we might need to be thinking about to address needs, opportunities, and challenges in rural communities? Because so let me before you answer, let me say this is that I believe, here's what I believe. I believe a couple of things. One is that the medically assisted treatment providers, buprenorphine, Suboxone, and methadone, if we can pull them into a continuum of care, treatment, and cure for HIV and Hep C, we can find out where the 20 to 25% of HIV cases are and where the 50% of Hep C cases may be. But I think that we also need people from those communities to be able to understand treatment, linkage to care, et cetera. So I think using them as training them to be community health workers,
Absolutely.
but figuring out other ways to engage, but also those are the dishwashers, that's the waiter, that's the guy behind the counter, that's the person on Main Street that needs the job opportunity too. And I think these things are connected to economic and workforce development in ways in rural communities that it may not be so much so in urban communities. I know I just talked for 15 minutes and you're like, what's the question? I don't know, Dan, so go for it.
You got it. Yeah. If I could be wax poetic a little bit here on this, I think that what has happened in this country historically is that we have decided that there's certain folks, whether they be Black, brown, poor, whatever, that we don't actually want to care for, meet what their needs are. And so what has happened in response to that is we end up criminalizing all these behaviors and all these people who just frankly have unmet social needs. And so what happens when we lock them away in the jail and we have something like the inmate exclusion policy, we're just invisibilizing the populations of people who have some pretty severe chronically unmet needs. And we're also taking away some of our tools to be able to actually help them. I have an aunt who has schizophrenia, and whenever she was in the midst of a crisis, the first responder was the county sheriff. That is not the way to be able to try and help her be able to get access to the care that she needs. So, you can just take that and imagine that on a scale in rural places all across the country, or in urban settings across the country. And what we're doing is we're criminalizing mental health needs. We're criminalizing people with substance use disorder. So by having this an 1115 waiver, allowing our health system to actually follow people wherever they are, allows us to actually meet people's needs inside of the jail. So no longer are we going to be invisibilizing the problems inside of our correctional facilities, but we're actually going to be saying we're going to allow our health system to shine into those recesses as well. And what's really, really cool about the 1115 waiver waivers is that many states that are applying for them are also saying, we want to fund peer support on the other side. So that as people are leaving incarceration, they can get jobs being peers. So they can say, like, the worst part of my life, the worst things that I went through in my life is actually something that's allowing for me to have some economic security now. And I can help guide some other folks out of that same position that I was in too. Not everyone's going to necessarily want to be a peer, but the folks that are can then help the other folks be able to get access to jobs. And frankly, too, I think that, if every single day you're worried about the police breathing down your neck and you're being arrested and taken in for unmet social needs, you're not going to really be able to sit around and think about how can we organize for more political power. And so by helping people be able to have some of their just, chronic low-level basal needs met around their health, their unmet health needs, it's a real powerful tool for down the road too, to create more opportunities for political organizing around supporting folks, around just being able to open up more opportunities on the other side too. So this was a really important key piece. It's another train, I guess, going as well, where we have the Medicaid waiver. And what that means is we're not going to be criminalizing mental health and substance use as much anymore. We're going to have new insights and transparency into what's going on inside of these settings. And we're also going to be creating a workforce of people whose, again, their worst days end up being something that ends up being healing, not just for them, but for other folks who are moving through these systems as well. And the caboose of that is some real organizing power on the other side to be able to say, you know what, we've been kept destabilized for a long time. There might be reasons for that. Now that we were kind of stabilized here, now we have a lot more that we can start asking for, and that we frankly are due.
Melissa, did you have a question? I saw your hand go up. Melissa, did you have a question? Or were you?
Oh, no, I was just clapping. I love it.
Okay.
Yeah.
Okay. Cool beans. All right. Audrey. So tell me the connectivity, right? Across department, especially. So, cause we had a call the other day with some folks, about a month ago now, but also with some folks in Tennessee. And one of the things they kept talking about is that they're trying to figure out the behavioral health piece to go with the labor piece, to go with the health piece. I mean, what did you see when you were working on the Hill?
I think lack of connectivity is a good word for it. I mean, a lot of these programs come out of different departments. They're funded through different areas. And this brings me back to my favorite topic, which is definitions are always different. And so it makes it hard to be able to apply for resources for various areas because you'll be eligible in one place and not eligible in another. And connecting everything is very difficult. I mean, and then there's also certain things such as, especially in behavioral health and substance use, Congress passed a 3-month continuing resolution, but there's key things such as the Support Act, which was the landmark 2018 substance use bill that it actually expired October 1st, 2023 and has not been reauthorized. And there's important programs
what
in
is
there.
that bill? Tell the people what that is. What is
that? It's the Support for Families and Communities Act. It includes provisions such as grant funding for ambulance programs, for training programs for behavioral health providers, various just substance use grants. There's a lot in there that had expired. I think Dan and could speak to these as well. And it passed, so it's some of the stuff we've been able to kick the can on, such as your SOR funding, SAPT funding, but other programs are in fact expired at this point and need to be re-upped. That helps with a lot of these workforce issues. Is it a silver bullet? No, but is it helpful? Yes. Other things that are expiring in March now are like GME programs that help with getting other behavioral health providers into communities. And you talk a little bit about Department of Labor workforce issues. This again, you get definitions issues for bringing in for what qualifies under certain programs. That could be the actual employment type, who's eligible under these programs. I'll go back to my favorite rural definitions. We were looking at even just international investment, EB-5 programs that want to invest in communities and bring economic opportunity to rural America. Congress passed a bill in 2021, I want to say, that incentivized investors to invest in rural communities, but they used an old definition that found that basically said that if you were in something called a metropolitan statistical area, you were urban, and if you weren't, you were rural, which meant that areas like, as I said, Boone County and large swaths of Appalachia actually are ineligible for that. So a lot of these communities that are economically disadvantaged are ineligible and can't get those investments. So, and again, it's different program to program, which makes it difficult to follow and know what's going on.
So, I mean, what do we do? I mean, if the building get funded, sounds like it's not a part of the new CR. What should people on this phone call be calling their representatives? What should people be doing? You don't forget, you don't work there anymore. You can say it now.
Yeah, I mean, you can't call me. I'm not as
No,
helpful
that's what
anymore.
I'm saying. I'm not gonna call you. They
But
can't call you anymore.
yeah, so
Who
the
should
current,
they call?
I mean, always, you should always reach out and flag these items. The current continuing resolution, which funds the CDC public health programs, currently expires in March. So Congress has to look at drawing up a different bill. We had originally negotiated a broader bill late December. It fell apart on the 11th hour, and so we got this much smaller version. The broader bill actually had the Support Act reauthorization in it. And so it was very, very close. So it's just kind of saying that this is a priority, that this bill needs to get done, that the lack of it moving forward is causing harm, and that funding for programs at CDC, at SAMHSA, at HHS, at HRSA are all vital and important, and that investment in these programs, I mean, I would say probably in this environment is when you invest in these programs, you can find savings down the line, which is always a tough argument to make, but if you can show that, it's always better. But always reach out, because if you don't, there's so much happening that it's oftentimes it's hard to know what items to focus on when you're working on these broader bills. And so, as I said, they'll be working on this now up until March when the current funding expires.
Okay, thanks. Dr. Driffin, what are we gonna do?
Oh my God. I think you're much better at crafting plans for us to
You
follow.
know that, but I thought I'd give you a bite of the apple too.
But no, I mean, I think it is continuing to lift up these important things. You know, I live here down in Atlanta, and I know a handful of our local elected officials. They always say if they receive an email from 5 people, they pay attention to something. You know, so I think it is going back and calling all of our friends to send those emails, you know, even if it's one of us just crafting the email for the 5 and just saying, just push this to ensure that the things that are important to us are on the radars of our elected officials. You know, my great state, our elected official works for 40 days out of the year. So this is the time right now, you know, to send those types of emails, send those types of requests, just to ensure that, you know, it is at the level that it needs to be.
Right, and thanks, Daniel, Dr. Driffin. And so I wanted to say that for me, you know, one of the pieces of this that I think is a critical piece is, you know, I really support, and I think, you know, we have our program called CHAMPS, our Community Health Worker Program. I think there's another level to this, right? And I think that level is that we need community health workers in all of these various sectors. Meaning we need them in the research sector. We need community health workers that are also in the public policy sector. I believe that we can train cohorts of people to do these things. I think when an organization like CEG walks in the door, you know, I think first thing they think is, oh, they're just from DC, they don't really care. Or they don't really know the area. And I'm like, but no, but we're not. We're not. Some of us might have been there and lived there once or twice, but this is what we do. And so I think figuring that part out is one piece of it. How do we get more community members access? And that's kind of like why we want to do things like this, right? So because I think if people don't know that there's a, 11, 15 waivers, and I think we can still talk, and I think, again, because I think people who don't also understand, we can still talk to the new administration. This is not too late. We can still keep working on this thing. I think that if we talk about the bill that you just mentioned, Audrey, we can continue to work on this thing. But if we don't get the information to the people on the front lines who this actually impacts the most, they don't know. And then all of a sudden there's a service that's not there, or a grant that's not reissued, or some money that they can't get, or a community health center that closes. And it's like, well, how did that happen? Because it was such great need to us. And that's one of the things that I think we want to do as CEG more of, is making sure that we can keep this information flow going. Because this is the bigger part of it, right? Is how do we make sure that we disseminate the information to the people that need it the most? And I think it's most important right now because we're addressing a syndemic of HIV, viral hepatitis, and substance use disorder. And why do I think it's so important right now? Because we are a year or better away from there being a new product on the market that I think changes the paradigm. 2 shots to prevent HIV, 2 shots to treat HIV. You go in, you get a shot at one point, you go in and get another shot in 6 months. And so if we don't know that in rural communities, if we don't know that in drug using communities, and what I like to say is that I think it's critically important that we infuse information in the social, sexual, drug sharing, spiritual, and familial networks, not just the individual who is the person using drugs. So what I'm going to now ask you three is, what's the best strategy for us to diffuse information into those networks? Harvey's like, I was coming here to talk about this topographical report. What you doing? Slick?
I don't think we are in the predicament to say what is the best one strategy. I think we have to do it all. It is sharing it across all of the different networks with key intersections. But in the same breath, it's ensuring that it's available through social media. It's available through traditional media. It's available on NPR. It has to be.
NPR, you fancy.
It even has to be in the penny circular that
Mountain Spotlight, Daniel.
mountain,
Mountain
thank you, the
Spotlight.
mountain spotlight. It has to be in everywhere. It has to be everywhere.
Right.
I also don't have, I agree. It's got to be everywhere. And I know I'm annoying my family. They're like, why did you move back to Ohio just to talk to me about Medicaid policy all the time? But I mean, because I was wrestling with exactly this question, how do I like talk to my neighbors about this sort of stuff that impacts their life? I was like, I've got to, since we can do things on Zoom now, I was like, I'm going to take advantage of this moment, move back. I could also afford to live here rather than trying to live in any of these other places. And have been annoying my neighbors about all of these things. And I think that this is a really important moment right now in time too to realize that we're in danger. We're talking about the gains that we've made and we're going to make, but we're on defense now on a lot of this. And I think it's really important to get out there the message that things like the Support Act, we would not have these 1115 waivers right now, but for the Support Act, which was passed during the last Trump administration. That was that statute ended up saying that CMS needed to start crafting these sorts of waivers. And I think that waivers are a really powerful democratic tool. And I know that you talk about bureaucracies and stuff and think that those are non-democratic, but waivers have open comment periods. They have days where you are supposed to be able to say, this is something important for our community, and to be able to provide that feedback. Each of these 1115 waivers that allows for Medicaid inside of the jail, that's going to be offsetting a lot of local dollars. And part of these waivers require that every dollar that's offset by a federal dollar has to be reinvested back inside of the community. I think that's a really important time and thing to organize around too, to say, this is what we know and need from in our community, and this is what we want these reinvestment dollars to go to. So it doesn't end up getting, paying for robot dogs or whatever they paid for with a lot of COVID dollars on the other side of it. So I think really understanding, and West Virginia has one of these waivers right now. Pennsylvania has one of these waivers. Maryland has one pending. North Carolina, they expanded Medicaid partially because sheriffs were so powerful a voice in saying we have unmet behavioral health needs. So even being able to rely on and create the strange bedfellows of alliances with community partnerships and sheriffs to say we need and want to protect Medicaid because Medicaid is the thing that helps us out when we are at our lowest and also helps us get back on our feet. These are like really important messages to get out here. And I'm in Ohio, like I said, and 1115s can go many directions. Right now, we have an 1115 that's in comment period right now. So anyone in Ohio who hasn't thought about this yet, you have until Friday, I believe it's Friday, to submit comments to say that Ohio's 1115 waiver that is requesting work requirements from the federal government is completely wrong-headed. What it's going to do is it's going to absolutely be taking Medicaid away from people who need it. It's going to be taking dollars out of the state. Medicaid dollars are a economic multiplier. For every dollar that's spent on Medicaid, you get about $1.50 back on the other side of it because that money goes to the labor, to the people who work inside of these, work inside of facilities, work on Medicaid programs. And to just start draining that money out in order to say that we think that these people over here aren't working hard enough to deserve these benefits is going to hurt all of us inside of the state. So I think that there's a lot of opportunity to get involved, not just at the statutory level, but also at the state level, and to start thinking about, who are the different bureaucrats whose chains I need to rattle in order to try and make sure that we're heard and that that these programs end up working for us rather than working for some politician's reelection campaign who says I should be reelected because I took benefits away from all of these welfare queens or whatever the people du jour that we want to try and demonize in this process.
And I'll add a little bit to that. Dan, I'm glad you talked about strange bedfellows, because one of the things, especially on a federal policy piece, that we would always look at is kind of creative solutions where there are a lot of strange bedfellows in this area. You mentioned sheriffs. A lot of the police departments and sheriffs in Appalachia receive funding through programs like high intensity drug trafficking areas. They have extra funding that they can utilize and partner to set up other programs that respond to public health. There's been partnerships with schools to help with some of the handle with care programs. There's also Department of Justice grants. Opioid affected youth is a grant program that I can think of. And I'm glad you talk a lot about Medicaid waivers. Medicaid is obviously a more consistent stream of funding than grants, but grants really do help with plugging holes and doing some short-term funding and even just creative funding for various items. So I wouldn't just look at HRSA or SAMHSA, HHS grant programs. Look at Department of Labor, look at Department of Justice, think creatively. Tony, I know you and I talked a lot about HIV funding in West Virginia. One thing that we had seen was West Virginia wasn't included in the initial ending the HIV epidemic program just due to how definitions were created. And West Virginia later was dubbed the most concerning HIV outbreak in the country. And EHE was having a hard time getting funded. And since they were in the midst of the grant program, West Virginia couldn't be added. So what we did is we increased funding to a separate program called opioid-related infectious diseases at the CDC. We increased that from about 10 million to 34 million with language in federal appropriations that said that the funding needed to be prioritized to states with high rates of HIV that weren't in EHE. Which happened to be West Virginia. And so it allowed for more programs to help prevent HIV and address the HIV outbreak and viral hepatitis, because it wasn't just HIV, it was also viral hepatitis and other infectious diseases related to IV drug use in West Virginia. And I think that also comes with educating community partners. And one thing we saw, especially during COVID, is it also matters who the messengers are. Studies have shown, especially in Appalachia, community members need to be those being the messengers. It's not always good to have necessarily a CDC official come in and be from Atlanta or from New York to come in and be the messenger in Charleston. You need individuals in local communities to be those messengers, which is why community health centers matter, because those are I think they serve now 1 in 3 patients in West Virginia. It's one of our lead care deliveries, sources of delivery in West Virginia. Again, community health center funding comes up in March. So it's good to bring that up with your federal officials, that this is important, it matters, it has broader impacts than just funding for a health center somewhere. It's how you message and reach out to individuals. Thank you, Sarah. 1 in 3.
Can I piggyback on that, since health centers have been brought up too? So one of the things that Coaches has been focused on since our inception was, who the heck is the person providing services inside of these jails? And, you know, just to frame things in terms of economics, which I hate, you have to translate moral things into money. But it is a major pain point and pressure point inside of jails, who provides the care there. And because it is so expensive often to provide care in there, the way it's been provided, it ends up being lower quality than one would expect in the community. Also, it helps that there's not a lot of transparency as well, so the quality ends up being lower. A major win that happened after Thanksgiving this year was that for the first time ever, HRSA said that community health centers, FQHCs, and lookalikes can actually move inside of the jail and provide services 90 days before release. This is a massive change too. So what this means is that there could be ways to craft the services delivered inside of a jail that would be able to be much better connected to the community systems, because it is the same provider. And also because FQHCs end up having a different reimbursement rate than normal Medicaid rates and the way that we do things normally, it's a huge and powerful opportunity to make a good case that our local FQHCs should be the providers inside of these facilities, and create a real opportunity for change of just who's the one delivering the care inside of these facilities as well.
Now, you know, I think that's, you know, you're hitting the nail on the head. So one of the bigger challenges that we see also, right, is the ability to get national recognition for the reimbursement of community health workers, right? So if we are going to have folks that are transitioning out of incarceral systems, jails, prisons, etc., and we say that these FQHCs are primary points of service access, you know, again, these are going to be communities that are probably more in need of connection points, right? Whether that's a connection point via transportation, or that's, in my opinion, a connection point via culture. And I think that a community health worker can provide a quote unquote service. I get you a rapid HIV test, or I get you a rapid Hep C test, or I link you to care, or I get you to treatment, or I talk to you about treatment. But the other thing I think that community health worker can do is shift an economy, right? They can shift the familial economy. You know, a lot of people are sometimes using drugs and accessing substances because they're unemployed. They got nothing to do all day, right? If I got nothing to do, guess what I'm gonna do? You know, Audrey, I gotta get you employment soon, because I don't want you to be calling me up going, hey, you got a program for me? You can always be a champ. You know, you can always come to the champs program, you know, right? If things don't work out, we got seats in the champs program. We got a cohort starting in about 6 weeks. All right. But, you know, seriously, is that so many people are in need of just a little bit of support, not help, but support to get to that next place. But we can't get these community health workers reimbursed at a flat across the country. It's if you're in Pennsylvania, it's this. If you're in West Virginia, it's that. If you're in Maryland, it's this. If you're in New Orleans, it's this. I mean, it's crazy. It's bananas. So can you three talk to me about kind of how you may have seen that, or what you think about kind of putting or getting this community health worker reimbursement on par with this 1115 waiver? Because the 1115 waiver is what I really think of as almost a model for how do you keep something as a system and a framework system.
So states, you're right. I mean, the United States is a patchwork of many, many systems smashed together, often creating blind spots or conflicts and things that just don't work well. Also, good opportunities of things to like exploit when they work in the way that for the people that we're trying to care for. So, just for example, as a part of the waiver that was just approved for Hawaii, which is a state that I've had the pleasure to work with a lot on this, they also asked for peer support to be covered as a Medicaid service, as a part of their Medicaid services. So, 1115s are very broad. Like I said, here in Ohio, while all other states are trying to march forward and have like good 1115 waivers, we're trying to go backwards and throw people off the rolls. Similarly, states can apply for Medicaid 1115 waivers and to cover peer support services or community health workers in ways that would be able to allow them to reimburse those sorts of activities. There also might be other really good reimbursement opportunities out there too that are just kind of outside of my area of expertise, but certainly these are being included in a lot of these 1115 waivers as a benefit or something that can be reimbursed.
Yeah, I can piggyback a little bit on that. I think kind of the purpose behind the 1115 Medicaid waivers was to allow creativity of states to be able to build their own Medicaid programs, as Dan outlined. Medicaid programs are different state to state, and it's because they're really federal state partnerships, and states can do their own. So you're not necessarily going to see that continuity from state to state on their Medicaid program. And this is where creative thinking comes in. So if you're talking about trying to do federal reimbursement, what are some of the federally controlled healthcare programs that kind of set targets for reimbursement for individuals? Look to Medicare. Maybe there's a way in which doing something to have Medicare reimburse peer specialists is good. And I will point again to the Support Act. It's not going to be your reimbursement, but even the House passed version last Congress of the Support Act reauthorization drastically increased the grant funding. Again, grants first, Medicaid reimbursement, but the grant funding to communities of recovery, which help fund things like people in recovery or peer support specialists. And so again, it's kind of putting a Band-Aid on a bullet hole, but it does help with funding some of these programs and individuals, especially in states that might not have appropriate funding for peer support specialists or community healthcare workers. You can help kind of support those programs best you can, and a lot of these resources tend to be targeted to communities in need. So economic issues, rurality issues, which is why definitions matter and why we look very closely at those.
And to piggyback on that too, there's other points of leverage as well. Like each state for their Medicaid plans, for those who are using managed care, they release RFPs for who's going to be the managed care plans that are going to participate there. That's another interesting point of leverage that you could have that be incorporated as a value-added benefit if it's something that already isn't inside something that you can try and receive money for through one of these different plans or one of these different programs. So think of the different places where the state is contracting for healthcare services, as Audrey was mentioning, or and maybe there are different points too in there where you can say, hey, request from all the people who are applying to include peer support services as a value-based purchasing. Or value-added benefit, and at the same time, they might not reimburse very well, might not pay people a living wage, but it could be a really interesting way to try and get some of the new managed care plans that are going to be managing the actual health programs inside of the state to offer that service as well.
Right. Okay. Dr. Driffin, you do a lot of work around the globe. What are you seeing with community health workers around the globe? Are they getting reimbursed? Are they compensated for their work? Does HVTN use community health workers at all? Or I don't know.
Yeah, so specifically at home with HPTN, we do use community health workers. Again, very similar to as Audrey was saying, I think we have a little bit more nimbleness, being that we receive large research grants from the National Institute of Health. So it gives us flexibility, to do what we really need, especially, at that intersection of community involvement and getting folks into trials or whatnot. I would say on the larger scale, outside of our specific research network, it's just a lack it's just a great decrease when we think about philanthropic organizations and what they're funding right now. I think it's across all boards, especially when we think about HIV prevention, treatment, and care, dollars have just drastically decreased, and we're even seeing that, something as beneficial as the Presidential Emergency Plan for AIDS Relief, known as PEPFAR, for the first time in a 20+ year history, we went from a 5-year reauthorization to a 1-year reauthorization. So I definitely think it's going to be a lot of changing things over the next 12 months, 18 months. And I think a lot of people are just trying to get ahead of these types of things.
If you have a question, we've got about 10 minutes left. If you have a question, you can do it one of two ways. You can put it in the chat, or you can come off of turn your camera on, and you can ask a question. Because we want you to feel like you're participating in this too. Even though you're not really. I mean, I know you're probably just recording this and you'll use it ChatGPT later to take some notes. But really, Daniel Raymond, you said that the HIV Hep C, no, you said the hepatitis C roundtable had a something on 1115 waivers. Are you still here? See.
Hey, Tony, can you hear me?
Oh, now I can. I was getting ready to start talking about you.
Oh, then I'm gonna sign off right away. Yeah, no, I just threw it in chat. We have been really interested in the opportunities to do more hepatitis C screening and treatment in correctional settings, jails and prisons that 1115 waiver provides. The CMS guidance to states on drafting 1115 waivers actually specifically calls out the opportunity to be more responsive to hepatitis C, along with the behavioral health stuff and 30 days prescription. So I just wanted to flag that for people who are interested. We've had a couple of really awesome webinars with some really smart people, and we're continuing to work with our partners at Center for Health Law and Policy Innovation on trying to track what's actually happening as states get their waivers approved by CMS and move towards implementation.
Daniel, can you hang out for a sec? Because I want to ask the panel, and I want to ask you a question. Do you believe that we have running room to continue with future 1115 waivers? And before you answer, I'm gonna answer. I think we do. And the reason I think we do is that I think we reframe the argument a bit on the end of this thing. That it's about jobs. It's like if a healthy workforce is a workforce. If you don't have a healthy workforce, you don't have a workforce. So Daniel, what are you guys saying about whether or not there can be more 1115 waivers going down the road? If you don't know everybody, this is Daniel Raymond. Daniel, tell the people who you are, because I'll mess it up on purpose.
Sure. Hey, everyone. I'm the Director of Policy for the National Viral Hepatitis Roundtable. I'll just say, and I think this goes to what Dan said at the beginning, these 1115 waivers are meant to be essentially cost neutral, that you may spend more in one area upfront, ideally to save more downstream. And so they are technically not meant to be a budget issue. I think the greater challenges to the Medicaid program at the federal and state level are really going to be proposals to do per capita instead of the way the entitlement program is structured right now, and to equalize the federal matching rates for the traditional Medicaid population and the population covered by expansion. I think that there may be a chilling effect on states' willingness to develop new 1115 waivers until they see where the dust settles with the reconciliation process. But I do think that there are some advantages to the 1115 model that mean that we'll have to see what the next CMS administrator's stance is towards them. But they do feel, as you said, Tony, viable to continue to pursue moving forward.
Perfect.
Yeah, if I could piggyback on that too, I agree, and it might be me being Pollyanna-ish about all of this too, but want to highlight two things. Yeah, I always say that really, I think that these 1115 waivers in particular, the reentry ones, are pretty secure because they've been approved across red states, blue states, purple states. The ones that make me nervous are the ones that are about health-related social needs, the ones that have been kind of expanding the authority of what Medicaid can pay for. So, and that's just because you know, it's just not as popular. But more reasons why these.
Dan, let me ask you, and this is where I interrupt.
Mhm.
Can you give examples of one of each so people will know what you're talking about? What's the difference between the two that you're talking about?
Yeah, so health-related social need is one that would, the waivers that pay for that are ones that would pay for things like housing, so first and last month's rent, or just something that would help support people that are traditionally not seen as like a health thing, but obviously impact health. And in a world where we're taking a good broader view of what impacts people's health would be something that we would want to try and support and pay for. The reentry ones are these ones that we've been talking about, paying for services 90 days before release. And that these ones, the 90 days before release ones, are the ones that have been, like I said, approved red states, blue states, purple states across the board. But also the 1115s themselves were something that were, again, just to remind you, this came into being because of something that was required in the Support Act that passed in 2018. Now, the Biden administration was the one who released the guidance, but the Trump administration was the one that said that we were going to investigate this and to release guidance on it. They just didn't get around to it before the end of their term. I also just want to highlight that there is also legislation that has been trying to modify the inmate of a public institution exclusion, something called the Reentry Act that would cover Medicaid 30 days before release, and also the Due Process Continuity of Care Act that would make sure that the entire time that someone's pre-trial, meaning they aren't convicted of anything yet, that they could maintain their Medicaid benefits that entire time. All of those have strong bipartisan support, and one of the originating co-sponsors of both of those bills was Vice President-elect J.D. Vance. So there's a lot of people that we could really hit them with if they were trying to say this isn't something we want. Be like, well, you wanted it before, and certainly they did. And there's a lot of things that we could point at for why these things should have staying power.
Perfect.
I will also piggyback. I think you mentioned reconciliation. I will note that there is, between confirmations and everything coming on this administration, just keep an eye on things. Even like the House Budget Committee, the current Republican majority and former one, even released their spending reform options of potential savings. They specifically listed Medicaid as potential offsets, listing per capita caps, quote, equalize Medicaid payments for able-bodied adults, limit Medicaid provider taxes, Medicaid work requirements, is all potential policy changes they could do as offsets for other things they want to move forward, or just general federal government savings. It's going to be interesting to see kind of where their priorities lie and where they're going to try to pull savings from. One note that I would flag, especially in Appalachia, West Virginia in particular, the ACA enhanced premium tax credits expire at the end of this year. And West Virginia is the state that benefited the single most from the enhanced premium tax credits. They get the highest amount due to population. And West Virginia saw the highest increase of enrollees enrolling in those ACA plans. It's not Medicaid, but it is private insurance that helps offset some of the reimbursement that other providers might receive from Medicaid or Medicare that might not be sufficient to for their operations. And if those premium tax credits expire at the end of the year, we could see a significant drop in health insurance enrollment, because prior to those, West Virginia did in fact have the highest premiums in the country on the marketplace. So just flagging that.
Again?
Prior to the enhanced premium tax credits that was originally put forth in the American Rescue Plan and then extended in the Inflation Reduction Act until the end of 2025, West Virginia had the highest premiums of any state, average premiums in the country in the ACA marketplace.
Wow.
That's just.
And was that because of the health condition, or because of the limited number of insurers in the marketplace, or both?
That's a number of factors, but yeah, I mean, part of the reason why you have a limited number of insurers in the marketplace, West Virginia previously only had one insurer that was in all 55 counties. West Virginia now has two in about 30 plus of them. You have a lack of competition, which drives up premiums. But part of the reason why you have so few insurers is because of that health condition. It's a very high risk environment to do business for them. And then also, West Virginia only recently started doing silver loading, so I'm not entirely sure how that will impact premiums if those subsidies fall off, but that could have an impact on reducing premiums moving forward, which is just kind of benchmarking various rates. So the insurance commissioner did switch to silver loading in the last few years. So that could change. So it's hard to say exactly what mixture of policies led to that. But generally speaking, West Virginia does have highest rate of pre-existing conditions, one of the oldest populations. West Virginia is third in the country for rate of individuals on Medicare, first in the country of rate of individuals on Social Security, high number of individuals on Medicaid. We get the second highest FMAP in the country, just behind Mississippi. So it's really disproportionate. And that's partially why we saw such an impact of those enhanced premium tax credits, which will expire at the end of this year and is also listed on that House budget list that Daniel shared as a potential area of savings. It's expensive.
Yeah. Dr. Driffin got out of here before I could ask him the next question, but it's actually 3:01. So again, if you have a question, put it in chat real quick. One of the things that I wanted to kind of end this with, and I don't know how to do it, and I'm hoping that maybe Lee and Lavina can help me figure out how to do this. But you know, one of the reasons we do this, and I wanted to start doing this, and I guess we've been doing it. This is our anniversary. I think a little about 18 months or so, was because many of the organizations on this call don't have a policy shop, right? And so, but they're these policies that really and truly impact them, their work, the people that they serve. So I guess, you know, you might be the pilot of the idea. This is how things go awry at CEG. You're getting ready to watch it in its natural and organic form. And everybody at CEG just went, what? And I'm wondering if each of you could give us a thing that the people could do, right? Like, Dan, you talked about, well, maybe they could write to their member about X, right? And Audrey, we've got this mapping system, but do we know that it's there? So maybe you can give us a paragraph on use this in the future, right? Because what we want to do is make sure that we share this information with them. And when I say that, I mean that so many of the organizations that we work with are on the front lines doing the hard work. And like I say, they don't know that the blah, blah, blah section of blah, blah, blah wasn't a part of the CR. Or that the blah, 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 blah didn't get as much funding as it did. And that's why they don't see the grant that they're looking for again. But we can maybe help people get some small doses of how to do things. And Lavina, that I know you're out there somewhere listening to this. And one of the things I'm thinking that maybe we do that we've not done in the past is that we start asking people if they want to do a sign-on letter. Let's go old school, back in the day, when I was a young whippersnapper policy person. Daniel Raymond, do you remember the old days when we would do sign-on letters? We do joint sign-on letters, and we get all the people together and say, here's a thing that we all agree on.
I am still reeling at the vision of you as a young whippersnapper, but yes, I remember.
It's true. It's true. Audrey, would you I know I've got what we were talking about with 1115s. What would you say your number one issue that folks on this call should be thinking about in the next upcoming session or in the next year? Or what would you say that thing is?
Ooh, that's tough to say.
In
There's
public.
I not just that, it's just there's a lot to we're entering a brand new administration. We have a new Congress, and a lot of priorities and things are going to change. Most immediately, I'm looking at the reconciliation and funding bills coming up because those are going to have broad impacts on a lot of these programs, and could include things like those health extenders. That's a DC term for community health center funding, graduate medical education funding, telehealth funding, and that Support Act reauthorization. And I mentioned the reconciliation bill because they could use cutting certain programs, changing programs to pay for things within it. There are certain rules that limit what they can do in reconciliation bills, and that is a very, very deep policy dive that is unnecessary here. But it's good to kind of maintain keep your eye on the ball there. It's hard for me to narrow it down to one thing, but those are the most immediate things coming up that I would be concerned about.
All right. Well, like I know y'all are not new to this, you're true to this. Audrey, you've always been not just, a staff, some people are staffers, but you've always been committed to West Virginia, you've been committed to the region, and you've been committed to rural communities across the United States of America. And so I always just appreciated your brain. I just always appreciated the way you always, when I would come with an idea, you would still tell me no, but you had turned it around enough where you knew, because you knew I was gonna go, well, what about? And you were like, yeah, no. And what about? Well, yeah, but no. And I always appreciated that because, not everybody turns the thing around, right? And I think that that's sometimes what we have to do. And I literally, I mean, if we had a genius award, I mean, I'm not MacArthur, but if I had a genius award, I would actually give it to you for the idea, and I know you're saying it was a whole bunch of people, but and Southern and genteel and be like, oh, it's a group effort of everybody. And but the thing is that idea around terrain, topography, I was like, chef's kiss. That was it. That James Beard Award for you. A Michelin star for you. And and so I want to, if nobody else said thank you for that, I want to say thank you for that, because I think that gives not just me, everybody on this call, but I think it gives organizations, institutions, local and county governments across the country a tool that they can use that they couldn't use before, that wasn't there. So I want to say thank you for having added something to the science of what we do.
It's my pleasure. And while I didn't end up writing the report, I will say it took a lot of advocacy and tenaciousness on our part, period 6 years to get it as far as it did. So I appreciate that. I don't know what to say, except it's really honestly been my honor to work with West Virginia for the last decade plus. And it's a bittersweet change moving forward, but I'm happy to still be able to join on these calls and talk about this, and hopeful that a lot of you can continue this good work. I have left a lot of the materials that we worked on specific to the ruggedness and rural definition with our other partners in Congress, as well as individuals, even on this call. So they have a lot of that data and information to hopefully utilize moving forward. Because all I know that I personally want to do is continue to see the health and welfare of West Virginia and everybody in Appalachia improve. So thank you. It's definitely bittersweet, but I've enjoyed working with everybody. I think here on this call are some of the most impassioned, hardworking frontline individuals I've ever had the privilege to meet. And I just sit in a DC office and try to think as creatively as possible.
Perfect. And I mean it from the bottom of my heart. I think that it just you're a rare gem, rare gem. And Dan, we just met, but like I said, oh well, you've been sucked into the CEG vortex now.
I'm happy to be there. Like I said, I'm a part of Appalachia, technically on paper, although I have no hills here. So I'm really grateful to be here today and to talk to you all. You're the ones doing the hard stuff. Yeah. We just send emails and annoy people all day.
Well, no, but thank you. I mean, because honestly, I think that what I really want to do, Lavina, I think we want to do a sign on about this. And I don't think that we have to do a boop, knock you over the head sign on about it, but just that we really believe that these have intrinsic value and they have value on Main Street, not just in those jails and prisons, but that they have an economic they can really make an economic impact in our local and county systems. And we have another piece, I think that somebody put into the chat about the kind of the community health worker models and how they can be either reimbursed or what have you. But we'd love to follow up with you and talk about kind of what some of those kind of priorities would look like. And I want to say have a happy new year, everybody. They tell me I can say that until the 15th, and then it's kind of like fish. It's stale and you get rid of it. But again, happy new year to everybody. I look forward to talking to folks next month. Dr. Daniel Driffin, I know that you probably had to take another call. Daniel Raymond, we're going to reach out to you maybe to help us with how we craft this 11:15 sign on. Maybe it's a joint one, but you know, we don't like you interlopers that come from out of town. So, you know, maybe we'll, you know, help you take your brain power and not tell the people.
Gotcha.
All right. Everybody have an amazing rest of the day. And thank you again. Thank you again to the team at CEG who put all this together and always make me look better than I am. All right. Thank you, everybody. Bye-bye.